Hi everyone, welcome to the YouTube channel. And today we are going to see when a patient comes with a high level of serum creatinine, how to evaluate this patient and how to assess this patient. So when a patient comes with a serum creatinine, what would you do? You would, right? Immediately to a nephrologist. Renal team, just blindly mentioning that patient has come with a creatinine of 280 and please do the needful. Is that what you need to do? As an MBBS or medical graduate, that's not what you should do. So, first of all, you would have to collect the patient's details, his demographics, name, age, address, ward, and his comorbidities, and what was his reason for getting admitted to the hospital. And the next question that comes to our mind is whether this patient would need dialysis. Why dialysis? When a patient comes with a shortness of breath, in medicine, usually the management starts symptomatically. And then once the patient is stabilized only, we would think about the definitive management. So if a patient comes with a shortness of breath, the initial symptomatic management would be to give oxygen and stabilize the patient's saturation. Whereas when it comes to renal impairment, as evidenced by a high creatinine, here, first of all, to stabilize the patient from renal failure, only support that we can give from the renal point of view is the dialysis. So we should first of all we need to identify whether there are any pressing indications to go for a urgent dialysis to stabilize the patient. So how do you do that? So we assess the patient. There are like kidney does so many functions in the body, but out of that, there are some essential functions. If that is not performed even for minutes, that would lead to life-threatening complications. What is that? Fluid volume overload. Second, the uremia. And uremia has to be on the severe form, like uremic encephalopathy or uremic pericarditis and refractory hyperkalemia. I'm using the word refractory hyperkalemia because there are medical options, whereas the hyperkalemia could be controlled. But when it doesn't respond to this medical treatment, then we call it as refractory hyperkalemia and severe acidosis, which does not respond for the sodium bicarbonate IV or oral. So these are the traditional indications for going ahead with the renal replacement therapy, as I have mentioned. Refractory pulmonary edema, volume overload, refractory hyperkalemia, refractory metabolic acidosis, uremic pericarditis, and sometimes drug overdose or poisoning. But now the concepts have changed. So we don't wait up until these life-threatening complications to occur to go for a dialysis. If we delay the dialysis, sometimes patient's life is at risk. So the current considerations for initiating renal replacement therapy is based on the clinical and biochemical parameters, and we should decide on whether there is a high likelihood of AKI recovering within the next 24 hours. If not, then definitely you will have to support the body with renal support. And this is a medical management protocol. So here You have to protect the heart, whereas hyperkalemia is uh, dangerous in situations where it can stop the heart in system, so that temporarily we send the potassium inside the cells with the help of insulin dextrose and salbutamol, but always ensure that the dose of salbutamol should be on the higher side to cause the side effect of not the bronchodilation, but to send the potassium into the cells to reduce the blood level of potassium. But that's not it. It can rebound. So to avoid that, we need to remove the potassium out of the body. For that, we are using some form of a potassium binder as calcium resonium or calcium zirconium cyclosilicate or lokelma. If these measures fail, then only we have to think about uh, dialysis. The next step of evaluation is we need to decide on whether this creatinine increment is due to AKI or CKD or AKI on CKD. So how to decide on that? For that, if you have got a baseline creatinine, what is baseline creatinine? Most of us do not know what is baseline creatinine. So if you see the AKI definition, everyone knows that it is the increase of serum creatinine by zero point 0.3 milligram per deciliter within 48 hours. So 1.5 times of baseline within 7 days. Or urine volume of zero point 0.5 ml per kg per hour for 6 hours. Right, baseline creatinine is stable. Most recent lowest creatinine is called baseline creatinine. But in our clinical practice, most of the patients do not come with a baseline creatinine. They have been followed up at uh, certain clinics, but they would have never checked a creatinine in their life. So if it is so, we can compare the current serum creatinine with the baseline creatinine, and we can take a decision whether it is AKI or CKD depending on the time duration. For an example, if the serum creatinine is 150 1 month back and the patient is coming with a creatinine of 400 within a month, then that indicates that the patient has got an AKI and CKD. Whereas if it is 150 1 year back and the patient is coming with 153, which means that there is not much of a serum creatinine rise, which could be due to a CKD progression. But there are clinical circumstances where the baseline creatinine would not be available. So in that case, what would you do? So if you have a doubt, you have to take it as AKI or AKI on CKD. Why is that? So if it is CKD, which means an irreversible damage, we would not actively look for any form of cause or renal impairment. Whereas CKD, so AKI, we would be actively looking for the cause and we would try to reverse the renal impairment. And the other important thing is that we need to have an idea about the input and output, so that we in our management we have to decide on whether it is a volume responsive acute kidney injury or AKI on CKD or volume unresponsive. Whereas volume responsive means you need to hydrate the patient well so that the urine output improves and the AKI gets better. And just opposite to this, if it is a volume unresponsive AKI, you will have to reduce the intake so that patient does not get an hydrogenic fluid overload. So this is what we do. So then, depending on the serum creatine trend, we could decide. Other thing is that we also look for whether there is any possibility of evidence of CKD. And if it is there, it is more towards CKD. And if it is not, as a diagnosis of exclusion, it is going to be either AKI or AKI and CKD. Right? What are the things that we look for as an evidence of CKD? First thing is that patient's general look, whether the patient is ill looking or well looking. So you can see that if the patient is having a creatinine of 700 and the patient does not seem to be ill looking, so which indicates that that renal impairment has been there for some time and the patient has got adapted to that creatinine. Whereas even if the creatinine is on the lower side and patient looks like 150 and the patient looks ill, so that is going to be an AKI. So the general look would give you a clue. And then second thing, radiological evidence of CKD. What are those? So shrunken kidneys with altered corticomedullary demarcation indicates that it is a chronic damage rather than an acute damage. So if it is a normal size kidneys, then the question arises, what is normal size? So 10 centimeter is the normal size. Anything less than 8 centimeter is considered to be a small shrunken size. But God has not left us with simple things. So there are CKDs that could arise with normal size kidneys. What are those? Diabetes, which is the commonest cause of chronic kidney disease. The number one cause of chronic kidney disease. So it comes with a normal size kidneys. And second differential diagnosis for normal size kidneys and CKD is myeloma. Anything that goes and infiltrates the kidney keeps the kidney sizes not altered with the same size. And then polycystic kidney disease usually has a large size kidneys, not a shrunken kidney. And fourth differential diagnosis, any lymphoma like infiltrative diseases. Then third clue is the native urine output. Usually, if it is an AKI, definitely the patient would come and tell you that his urine output has reduced. So either anuric or oliguric. But when it comes to CKD, they will strongly tell that it is their urine output is normal. Why is that? Because the urine output gradually declines. It's not an abrupt decline. So that patient does not notice that their urine output has reduced. So patient would not be aware about reduction of urine output. But if you quantify it in a ward setup or inpatient, it would be in the lower value. And then fourth evidence is biochemical evidence. That is, patient would have anemia, hypocalcemia, hyperphosphatemia, and hyperuricemia. So this is the biochemical evidence of chronic kidney disease. And then if these features are there, it is more towards CKD. So then your job is to find out what could have caused this CKD, whether it is diabetes, which is almost the universal cause for 80% of chronic kidney disease, and which is followed by hypertension, which is the next commonest cause, and chronic glomerulonephritis, polycystic kidney disease, and in some part of the world or endemic area, CKD. So the first question that we try to answer when a patient presents with a high serum creatinine, whether the patient needs a dialysis. Second thing, what is a renal diagnosis, whether it is AKI, AKI on CKD or CKD. And the important thing is that AKI or CKD is not the diagnosis, but we need to identify what has caused the renal impairment. How do we identify? So as we have studied in the medical school, it could be due to pre-renal, renal, or post-renal. So when it comes to pre-renal, as we know that we need to go through the history to find out whether there had been any volume loss, blood pressure drop, any cardiac cause which is not pumping enough blood to perfuse the kidneys, and any liver abnormality which is going to keep the blood within the portal circulation and compromise the systemic circulation so that the kidney does not get enough blood supply, leading to hepatorenal syndrome. And when this happens due to the heart failure or cardiogenic shock, and renal function is compromised, we call it as cardio-renal syndrome. So how do we manage this pre-renal? If we identify this pre-renal mechanism, then if it is volume loss, you need to replace the volume. And if it is low blood pressure, then you will have to top up the blood pressure with fluids and inotropes. And then if it is cardio-renal syndrome, how do you manage this patient? So because of the heart not being able to pump the blood into the systemic circulation, the blood pools in the venous side. So as like a bullock pulling the cart, it's finding it difficult. It's not moving. What do you do? So if you should try to offload so that the bullock could pull the cart. So we need to offload it from the venous side. So how do we do that? So we need to restrict the fluid, restrict the salt, and use diuretics to increase the urine output and get rid of that excess fluid which has accumulated in the venous return. That would improve the that would reduce the workload to the heart, and that would improve the pumping action of the heart, and then improve the systemic perfusion pressure and blood supply to the kidneys. And when it comes to the liver abnormality or hepatorenal syndrome, you need to become a Robin Hood. That is, when a liver is diseased, it thinks that it is the only organ that needs the blood. So that what it does is it gets all the blood into the portal circulation and keeps it there. Even in normal situation, it has dual blood supply, as evidenced by it is the blood is given by hepatic artery and portal vein. Whereas then all the nutritious food, nutritious things are going to the liver through the portal vein. So when it is diseased, it dilates its portal circulatory blood vessels and just keeps the blood within the portal circulation so that the systemic blood circulation is compromised, so that the kidney is compromised. So what do we do? So we become a Robin Hood, steal from the rich and give it to the poor. So that is what the Robin Hood is famous for. So we take the blood from the portal circulation and squeeze it to the systemic circulation. So how do we do that? So we use a vasoconstrictor that could specifically constrict the portal circulation and put it into the systemic circulation. Who does that? And it should not compromise the systemic circulation, the vasoconstrictor. So we know that terlipressin does this job. So we should use terlipressin. And not only the squeezing the blood vessels is not enough. So it has to stay within the blood vessels intravascularly. And it would leak into the third space because there is low albumin uh, because of the liver failure production. So in that case, we should combine it with albumin and terlipressin, which would keep the systemic circulation, and that could improve the systemic perfusion pressure and renal perfusion. So this is how we manage the renal failure. And so it's like a left hand of a medical person. They need to exclude the pre-renal element first. And by the right hand, they have to exclude the post-renal part. How do you do that? So what is post-renal? So the urine is produced, but the pathway is obstructed due to some obstruction. So how do we exclude it? It is by the imaging. So we can put our head inside the renal tract and see whether it is obstructed or not. But we do external imaging to find out whether there is any hydronephrosis or hydroureter. And if that is the case, then we should refer to the urology team for intervention and to relieve the obstructive element. So now we come to the nephrology part here. So far, as you can see, the nephrology team is not needed. So this is general medicine rather than a nephrology. So if you have excluded the pre-renal and post-renal as diagnosis of exclusion, it could be due to the intrinsic renal causes. So how can you confirm that? Because we are practicing evidence-based medicine, so we should confirm it. So how do we confirm it? Can we put our head inside the kidney and see whether there is any abnormality? No. So it is by the end product of the kidney. So what is the end product of the kidney? It is urine. So we get a urine full report and do the urine analysis. Usually we look at three things: pulse cells, red cells, and protein. So which indicates, so if I ask you, what is the usage of urine analysis when it comes to renal impairment? What would be your answer? So if there is a infection, the pus cells are more, then you can't interpret the rest of the urine analysis. You'll have to treat the infection with after taking urine culture and waiting for the antibody sensitivity test with an antibiotic, and then reassess again. But if it is suggestive of there is hemoproteinuria, which indicates that there is blood, there is protein, which indicates that the glomerular filter has been affected. So that is the answer that you need to give. It doesn't mean that intrinsic renal failure, it is a broad term. Within that, if the urine contains hemoproteinuria, then that indicates that there is a glomerular abnormality. So that is the only thing. So we should be able to interpret the UFR confidently. So if the urine full report has hemoproteinuria, it is suggestive of GN. So proteinuria. So when it comes to proteinuria and hematuria, then you'll have to just get an idea about, okay, now the glomerulus have been affected. So how severe the abnormality is. So how do we identify that? So we quantify the proteinuria and we get the urine PCR or urine albumin creatinine ratio or urine ACR. And when it comes to hematuria, we need to identify that it is due to the glomerular in origin and not non-glomerular in origin. So how do we differentiate? So if it is dysmorphic red cells, a significant amount, then it is more suggestive of a glomerular origin, because the red cells, which is the naughtiest one, should squeeze through the small defects and come out so that their morphology gets dysmorphed. So there is no clear cutoff of how many percentage of dysmorphic RBCs are significant. But if it is a predominantly a dysmorphic RBCs, then it is suggestive of glomerular in origin. Like would be glomerular in origin. But when it comes to vice versa, that is, if there is no dysmorphic RBCs, we can't exclude glomerular pathology. Why is that? If the defect is larger enough, the red cells would squeeze through without damaging its morphology. Explanation is simple. Similar as if the NS1 is negative, you won't be able to exclude dengue fever. Okay, this is about the glomerulus. And there is a terminology called RPGN, rapidly progressive glomerulonephritis. What it is? So when this glomerular pathology is rapidly progressing, there is hemoproteinuria to say that GN, and we need to show that it is rapidly progressing. How do we show that it's rapidly progressing? The creatinine would rise rapidly. Then we call it as RPGN, which is a nephrological emergency. Why it is an emergency? Because by the time that you delay the treatment, you are going to lose the glomerulus or the nephrons. So you have to act quickly and start the treatment early. And if you take the glomerular pathology, most of the time, out of 99 out of 100 times, it is an autoimmune uh, mechanism that damages the glomerulus. So what is the treatment? It is immunosuppression. But the level of immunosuppression depends on whether we are going to stop with the steroid monotherapy or whether we are going to top up the immunosuppression to antiproliferative or calcineurin inhibitors or cyclophosphamide like cytotoxic medications or rituximab, or whether we are going to go ahead with the plasma exchange. Or it all depends on the severity of the glomerular abnormality. And I have left 99 out of 100 times it is autoimmune pathology. Then what is the rest of 1%? 1% could be due to the infection itself, right? We call it as infection-related IRGN or infection-related glomerulonephritis, whereas treating the infection would would treat the glomerular abnormality. So if the urine full report is positive for hemoproteinuria, it could be glomerular pathology, and again, the nephrology team should get involved, right? What about the other three? If it is a tubular abnormality, or if it is a interstitial abnormality or vascular abnormality, how do we decide? So far, is there any investigations that could help us to come to this conclusion? No, that is unfortunate. So it is like a diagnosis of exclusion. So we exclude the glomerular pathology, and if the urine full report is normal, then we presume that it could be either of tubular pathology or interstitial pathology or blood vessels related or vascular pathology. And we retrospectively look for whether there is any evidence to say that this could have led to this tubular abnormality. So overall, within the whole body, the most susceptible tissue for ischemia or the hypoxic damage is the renal tubular epithelial cells. So that is why the God has created two organs which is most sensitive to hypoxia or ischemic damage with autoregulatory mechanism. One is kidney and another one is brain. So when this ischemic damage or hypoxia overcomes that autoregulation and it is prolonged hypotension, ischemia, then it leads to ischemic ATN. And these tubular epithelial cells, when it comes to in contact with some other toxins like myoglobin or any form of herbal medications, it necroses itself, and we call it as acute tubular necrosis. And once this is developed, you would see a muddy brown color urine, and that would take ages for it to recover. Up until that time, you have to support the body with hemodialysis. But you can prevent. So when a patient is having a reduced perfusion pressure, you have to act quickly and restore the perfusion pressure so that the ischemic damage is not prolonged and it doesn't go into the acute tubular necrosis. Similarly, so if the patient has been exposed to some form of a nephrotoxins like any form of drugs, antibiotics like penicillin and non-steroidal anti-inflammatory drugs or herbal medications, it could cause a tubulo-interstitial damage and cause tubulo-interstitial nephritis that could give rise to an acute kidney injury. And the vascular causes as last, right? If a patient has a diarrheal history, low platelet, low hemoglobin low, and blood picture showing a microangiopathy, hemolytic anemia, and evidence of biochemical evidence of hemolysis, then it could be due to hemolytic uremic syndrome or TTP. So this vasculitis causes AKI with glomerular abnormality, not this. So this vasculature being the cause for the AKI is due to this atypical HUS or TTP. And I have purposefully added this renal artery stenosis and renal vein thrombosis here, which could be a pre-renal element, which is very rare and which needs Doppler scan to have a suspicion. So this is how you identify. So the diagnosis that you need to write is AKI on CKD secondary to what? So most of the time, what are the common causes of AKI? First one is sepsis, which stands for, which almost contributes for 70% of the causes. And latter 20% is by the iatrogenic cause of medications. And other 10% is the other causes. So you'll have to treat these So look for sepsis, and the management comes with a shout protocol when it comes to AKI. That is, it stands for sepsis control. It stands for hydration and correcting the hypovolemia, and O stands for obstruction exclusion. And if it is there, referral to urology for intervention. U stands for urine analysis, and if the infection is there, treated, or hemoproteinuria is there, then it is towards glomerular pathology and refer to the renal team, get done a renal biopsy to evaluate for the severity of the glomerular abnormality, and start treatment with immunosuppression. And T, SHOUT, stands for toxins. So you withhold all the nephrotoxins like antibiotics, NSAIDs, and that would improve the AKI. So simply, this is how you work out a patient coming with an AKI.